Okay, right. So today we are going to talk about PK/PD of antibiotics as the kidney matters. So PK/PD is a very important concept in this thing. So let us see what it actually means. So PK stands for pharmacokinetics and PD stands for pharmacodynamics. Simply speaking, pharmacokinetics is what the body does to the drug. That is absorption, metabolism, excretion, protein binding, volume of distribution, etc. These are all characteristics of a drug which the body does to it. And pharmacodynamics is what the drug does to the body. That is, the action, changes in physiology of the drug, the side effects, etc. And the PK/PD approach is probably the best way to prescribe antibiotics and adjust dosing. For understanding what is the PK/PD approach, we have to go a little bit deeper into the subject. The fundamental theory of PK/PD stands on this equation where dose is equal to body clearance into therapeutic concentration by bioavailability. So if you look at it this way, the body clearance is what determines the actual amount of drug in the body. The clearance is equal to the total amount of drug which is being present in the body. And you multiply that by therapeutic concentration, you will know exactly how much drug needs to be in the blood in order to produce it. And bioavailability determines how much drug is actually available there, because if the bioavailability is, say, 10% only, you will need 90 times the amount of drug you give in order to achieve this particular thing. So basically, it's dose equal to body clearance into therapeutic concentration by bioavailability. And the MIC is positively related to therapeutic concentration, because only if if it is above the MIC, it can be a therapeutic concentration. So if you look at it, this is a PK concept. Bioavailability is again PK, and therapeutic concentration is actually a PD prospect. So what is the MIC? The minimum inhibitory concentration, the lowest antibiotic concentration at which complete growth prevention of the organism occurs in the culture media. So it's actually in vitro MIC. It's more difficult to do an in vivo MIC. But using MIC to guide therapy provides only the potency data. For instance, even if the antibiotic level is above the MIC, this may not be enough. We should know how long it will be above the MIC, what happens when it falls below the MIC, whether it changes, whether the protein binding and other things will keep it above the MIC or not. Therefore, you should combine with pharmacokinetic data in order to really apply the effective MIC. And when you apply that, what exactly happens? So you can see this graph. This is how time concentration graph of an antibiotic. So antibiotic level starts with 0, and as the levels rise with intravenous or oral administration, it reaches this point, which is known as Cmax, so the maximum concentration of the drug. After that, it keeps falling down until it reaches a 0 level after some time. So there are three concepts here which are important in the PK/PD of a drug. One is the Cmax. The second is the area under the concentration curve, or AUC. And third is the time the antibiotic concentration remains above the MIC. And based on this, you can divide antibiotics into two types, which have concentration-dependent killing or time-dependent killing. So time-dependent killing antibiotics have to maintain a level above the MIC all the time. Otherwise, they are not effective. Concentration depending, on the other hand, may depend upon the AUC or the Cmax. So it's not important to keep it above MIC all the time. Once you achieve a good AUC or a Cmax, that is enough. The rest of it is taken up by the antibiotic. So to expand on this concept a little bit, this small table which gives you the major antibiotics that depend upon time dependent or concentration dependent. You can see that beta-lactams are mainly time dependent, and so is trimethoprim and erythromycin. Aminoglycosides and fluoroquinolones are concentration dependent, as are tetracyclines and vancomycin. But we need a little bit more about these things. So what do you mean by time dependent killing, or T above MIC? So the prototype antibiotics are the beta-lactams. So by increasing the drug concentrations, there is no effect on outcome. But if you increase the time of exposure, you can improve outcomes. So just because you give meropenem 1 gram in one shot as a bolus, that will not help you achieve good antibiotic killing. But if you give the same dose 1 gram over a period of time, that is prolonged infusion, that is 3 to 4 hour infusion, then you can improve the outcome, because all this time you can keep the antibiotic level above the MIC. So even a 1 hour infusion may not be enough in sick patients. If the patient is not that sick, you can always get away with a 1 hour infusion. But in sick patients where you want to achieve excellent antibiotic effect, you have to give more infusions. In fact, there are centers where they do 24-hour infusion of antibiotic. That's technically very difficult to do, because this drug is not stable in solution. So after 3 hours, meropenem is not stable. It has to be discarded. So you'll have to go on giving more and more meropenem. And so you have to go on maintaining a particular IV line and all those things. So it's quite difficult to maintain it in a 24-hour infusion, which may actually improve the action of the drug by keeping the drug above MIC all the time. So that is a very important concept in this, that beta-lactams act by time-dependent killing. So you have to maintain a concentration above MIC all the time. So if the action of the drug declines, for instance, a short-acting drug like penicillin, it's a very short-acting drug, so you have to give frequently 6-hourly or 4-hourly in order to keep it above MIC all the time. Otherwise, it's not effective. And if you're going to give beta-lactam, say in renal failure, we'll come to that a little later. Second thing is concentration-dependent killing, or AUC more than MIC. So here what you're trying to maintain is maintain the area under concentration curve above the MIC all the time. So here you can measure the free drug levels and keep the AUC over MIC. That's the important parameter. And here fluoroquinolones and vancomycin are the important agents. So what happens here that for quinolones, actually toxicity is not limited. So it doesn't really matter how you give it. You can give it once daily, twice daily, whatever. So you can maintain that. But for vancomycin, you can't afford to do that because you give too much, you're going to produce toxicity. You give too little, you're going to develop resistance. So therefore, that is why for vancomycin, you have to monitor an AUC. In fact, previously we used to monitor vancomycin trough levels, but now the recommendation is you monitor the AUC instead of monitoring trough levels. For monitoring AUC, a 2-level monitoring is enough. You measure it at 2 hours after and the trough value, and then based on both of these, you can calculate the AUC and you can monitor vancomycin levels. But therefore, why it is important, because trough levels often, if you are monitoring, they may underestimate the exposure to the drug. Therefore, you may develop toxicity even though you think the trough levels are okay. So that's the problem monitoring trough levels with vancomycin. You really need to monitor the AUC, especially in patients with CKD, where this levels are very difficult to imagine. And lastly, about concentration-dependent killing, this is a much more easier to understand concept, is that Cmax should be above MIC. That is, the maximum concentration should be above MIC. That should be a very easy thing to do. Aminoglycosides are the typical agents of this class. So what you need to do is you give a dose and achieve a high level, that's finished. You don't have to bother about AUC, you don't have to bother about time, everything. That's why it is said that it's best to give one single high dose in the morning. So if you are giving, say, amikacin, you give 15 milligram per kilogram, one single dose, and that is enough. And the advantage of that is this high Cmax and subsequent non-exposure to antibiotic will help prevent side effects. So the renal toxicity and ototoxicity are prevented by giving single dose rather than giving twice daily or thrice daily. So you understand the basic concept of time dependent versus concentration dependent. And lastly, there is something known as post-antibiotic effect. This is the effect of an antibiotic even after levels have come down to below MIC. Because you know that this antibiotic can remain in the tissue, can remain inside the organism, remain inside the ECF for a much longer time. And once it has started killing, the effect may be prolonged for a certain period. And that is why this post-antibiotic effect is significant. If you look at gram-positive organisms, almost all the antibiotics have significant post-antibiotic effects, so really not that important. If you look at beta-lactams have the lowest, about 2 hours, but vancomycin has more than 5 hours. So even if the levels fall below trough, it doesn't matter, it is still acting. And if you look at antibiotics affecting protein synthesis like aminoglycosides or nucleic acid synthesis like fluoroquinolones, both have a longer PAE. Aminoglycosides are as high as 6 hours. So even if their time of action is only 12 hours, giving once a day may be more than enough because of the significant post-antibiotic effect. And fluoroquinolones also have long, at least 2 to 3 hours for each of them. And again, gram negatives, you can see that the beta-lactams do not have any significant post-antibiotic except carbapenems. Carbapenems have about 2 to 4 hours against Enterobacteriaceae. That includes E. coli, Klebsiella, all those things, and Pseudomonas. So this post-antibiotic effect is a very important concept in addition to the time and concentration dependent killing. So you can add, it's an additive effect to their original mechanism of action. Now, a little bit about CKD. Now, as we know, this global prevalence is almost 10%. There are a huge number of cases. It's very common nowadays. It was not that common when you're studying, I thought, but nowadays you see CKD everywhere. Patients presenting CKD are particularly vulnerable to infections because they have poor humoral and cellular immune responses. And infectious disease is the second leading cause of death in end-stage CKD patients, in dialysis patients especially. So antibiotic treatment is common and requires special attention. And nephrologists, more than any other specialists, need to understand antibiotics, how to use antibiotics. In fact, every antibiotic situation, because we are commonly called upon to use difficult to use antibiotics in the presence of CKD. And it is our input that is most important when antibiotics are being prescribed in patients with CKD, even if there are patients, even if there are ID consultants and other involved. So what does CKD do on antibiotic pharmacology? So due to the pathophysiological changes, you have impairment of renal elimination. That's the most important thing. But at the same time, kidney can also affect absorption of drug, distribution, because it affects albumin levels, and volume of distribution also is affected by kidney failure. And it affects metabolism because many of them may undergo metabolism through the kidney. So all these things are affected by kidney failure. So that leads to accumulation of drug and toxicity if doses are not adjusted. And the most important examples are neurotoxicity of beta-lactams, and the renal and autological toxicity of aminoglycosides and glycopeptides. So these are the basic problems that you have in a patient with CKD when we are prescribing antibiotics. So how do you adjust doses based on PK/PD? So for time-dependent antibiotics, you have to decrease the dose and keep the dosing frequency constant. So if you want to give, say, for instance, meropenem, you better to give it as 500 milligram BD rather than give 1 gram daily, because you can then keep higher more time at which the antibiotic level is kept above the MIC. For concentration-dependent antibiotics, you keep the dose same and prolong the dosing interval. So for especially aminoglycosides, you are going to give it once in 2 days, once in 3 days, once in 4 days, etc. That's how you're going to do it. Even vancomycin, we know that. So the main objective is to obtain a concentration of antibiotic within the therapeutic range, avoid toxicity, and therapeutic drug monitoring for most of the agents. Even in aminoglycosides and vancomycin, the TDMs are available only in a few hospitals. So many of us will not have access to these things. And if you are going to send it outside, if you send aminoglycoside level and you get it after 5 days, it is of no use to anyone. So effect of dialysis is also important, because dialysis will cause increased clearance during the dialysis, and after dialysis, there is no clearance at all. So there is a major shift in the antibody levels during and after dialysis, which creates problems when you're prescribing antibiotics. So a little bit about antibiotics. In general, beta-lactams exhibit time-dependent pharmacokinetics, but CKD will make it easier to achieve PK/PD targets. Because of the prolonged duration of action, you can just extend the time at which you give. So instead of giving TID, you can give BD. But don't go for OD, even if OD is suggested by some others, because BD is far better, or TID is far better than giving it. And recent days, the loading dose followed by extended continuous infusions have been proposed to maximize the time that concentrations stay above the MIC. And when doses of beta have not been adjusted, you can get seizures and other complications due to them. So if you look at the individual beta-lactam, look at penicillins. Penicillins have very short half-life, usually about 0.5 to 1.5 hours in normal kidney function. But they have very significant tubular kidney secretion. So this secretion is lost in the presence of CKD. Therefore, their half-life is increased. So this can lead to dosing problems, but generally problem is that you can give penicillins even higher dose. They are well tolerated. So not much of toxicity. So it doesn't matter even if you give higher doses. So really it doesn't matter as far as penicillins are concerned. Continue same dose. It doesn't really matter. Maybe instead of doing 4 hourly, you can give 6 hourly. Or if you are giving for meningitis a 2 hourly dose, hardly anybody uses penicillin nowadays. So it's not a very difficult thing to talk about. And if you got allergic reactions, there is no increase in allergy just because you have CKD. So it doesn't really matter. Cephalosporins are used to treat gram-negative infections. And we generally use 3rd and 4th generation cephalosporins. So if you use ceftazidime can be dosed 3 times a week after dialysis. That's a very useful thing. You give 1 gram after dialysis 3 times a week. In some conditions, you may give 2 grams 3 times a week, but 1 or 2 grams after dialysis is sufficient for achieving target levels. And you found that with these concentrations, MIC for more than 45% of the time was achieved, and therefore more favorable outcomes are seen in patients with hospital-acquired pneumonia. But when there is a critical infection or neutropenia, you may like to give once daily instead of thrice a week or something. So that may be one situation, but otherwise, generally, for instance, if you have Burkholderia or something like that, you can always give ceftazidime 3 times a week. Aminoglycosides are problematic drugs in CKD. You can give these drugs, they have very extended half-life in CKD, 30 to 60 hours. So you may need to give it once in 3 or 5 days, especially as their accumulation of renal cortex is approximately lasting for about 100 hours. So they excrete the drug from the kidney itself takes a long time, and therefore risk of nephrotoxicity is very high, especially when you have these factors such as pre-existing renal disease, dysfunction, or concomitant use of other drugs and volume depletion, acidosis, etc. So all these things can cause worsening of the aminoglycoside nephrotoxicity. So one of the things we do is we give it after dialysis. So giving it after dialysis will produce an excellent Cmax, but the the volume will come down only after the next dialysis. So you can give another dose after the next dialysis, especially as it has got post-antibiotic effect. So even during the dialysis, when the levels come down, it doesn't really matter. But recently there was a study showing that you can give it before dialysis, because again, it will achieve good Cmax before dialysis and the levels come down. So you can, maybe the second or third dose you can give before dialysis, because what will happen then is that you achieve Cmax, but you don't get toxicity. Normally what we see is that if you give more than 2 or 3 doses of aminoglycosides, you are going to develop ototoxicity. I don't give more than 3 doses of aminoglycosides consequently after dialysis. So not more than that. But one of the things may be that in the 3rd dose or 4th dose you can give before dialysis in order to reduce the ototoxicity. And this is the summary of the recommendation. Amikacin 15 mg per kilogram dose, and with a low creatinine levels once in 48 hours. In dialysis patients, maybe once in 5 days may be enough, but you can give a small dose maybe after the next dialysis. And what about other antibiotics? So if you look at erythromycin, dose adjustment only if the GFR is less than 15 ml, whereas clarithromycin, even a GFR less than 30 ml, you have to adjust it. And quinolones, generally, you can give it once daily. That's actually a much better way of dealing with it, because there you achieve good AUC with if you give once daily and you don't develop toxicity. One of the problems with quinolones is that you may develop seizures with higher doses. But in general, they are safe. So a little bit of overdosing doesn't matter. Once in a while, a seizure-prone patient may be in trouble. That's the only thing. And second thing is prolonged QT interval, which can occur in these drugs. So that may be also a problem. And teicoplanin vancomycin. So teicoplanin loading dose and dosing adjustment depending on steady-state plasma concentration. Vancomycin also requires steady-state plasma concentration. So you have to monitor AUC. So it's not easy to prescribe unless you have access to an AUC, because just saying that giving vancomycin once in 5 days is not at all effective. Some people achieve concentration, some people don't achieve concentrations. So it becomes a lottery as to whether the patient develops good control of infection or not. And after treatment, how do you monitor these patients? Measurement of plasma levels is justified for all antibiotics, especially with a narrow therapeutic index. So most important is vancomycin and aminoglycosides. So TDM remains always insufficient and usually focus only on small molecules. So ideally, you should monitor everything. Even if you're giving penicillin, meropenem, whatever, you should monitor their TDMs and then see whether you are accurate or not. And how do you select antibiotics? So preferably, we prefer non-nephrotoxic antibiotics. We don't want to use aminoglycosides or vancomycin unless necessary. But we do use vancomycin in dialysis patients because of the ease of administration and single dose rounds. Therefore, cost really comes down. So you have to look at the infection site, the severity of infection, what is the bacteria which is there, and the ecological impact of antibiotics. So are you going to produce more resistance, less resistance, whatever. Then you can select an alternative antibiotics with a correct dose adjustment based on the renal function, which has a broad therapeutic index. And if you can perform PK/PD parameter monitoring, that should be very good. And as far as possible, avoid empirical prescriptions with standard dosing, whatever. So in summary, infections is the second leading cause of death in end-stage CKD patients. Antibiotic prescribing is difficult, especially in patients with kidney disease, but knowledge of a drug's pharmacology, its role in therapy, and PK/PD, you can just find out based on this how to prescribe the antibiotic effectively and minimize the adverse effects. And you can classify antibiotics either time-dependent or concentration-dependent based on their characteristics. And based on that, you can do a much better job of prescribing antibiotics by adjusting the doses, the timing, the frequency, etc. And the appropriate use of these antibiotics is essential to ensure efficacy and prevent the emergence of resistance. Thank you very much.